Hello and welcome to this Vulval Pain Society social media live. I'm Sheren Gaulbert, Vulval Pain Society trustee, therapist and pain science educator. If you can say hi in the comments, then I'll know that you're able to see me, and I'll be looking over to make sure I can see some comments. So if you're watching live, please do say hi, whether you're watching on Facebook or on YouTube. Of course, you can say hi if you're watching the replay too. Kay Thomas, our operations director, is also in the background on Facebook. Any questions you may have as we're live, please pop in the comments and I'll keep an eye on those and see whether we can put them to our guest today, who is Cath Reeve-Jones.
Hello.
Hi, senior midwife at the Midwifery-led Barkantine Birth Centre. Cath, lovely for you to join us. Could you tell us, first of all, a little bit about yourself, what it was that first brought you to where you are now, and then a little bit more about the Barkantine and what makes it different?
Right. Okay. So what brought me to midwifery was having my 3 children. I was 20 when I had my first child, and that child was born at home. And then I had 2 more babies born at home, and having amazing caregivers, amazing midwives look after me, giving me the choice and the freedom to birth how I want was the inspiration for me becoming a midwife. And I trained just after my second child was born. And yeah, I've been 24 years catching babies and 11 years at the amazing Barkantine Birth Centre. So the Barkantine Birth Centre is on the Isle of Dogs. It's a 5-bedded freestanding birth centre. So it's run by midwives. There's no doctors, paediatricians on site. We serve a huge Bengali community. It's in one of the most ethnically diverse areas of London, if you know Tower Hamlets. The main hospital is the Royal London, and they offer 4 choices of birth. You can birth at a freestanding, an alongside birth centre, at home, and on the labour suite if you choose, which is quite incredible. And they've kept us open through COVID, which is very unusual because a lot of midwives were moved across to the main unit during COVID. So we're very proud that we've stayed open.
Okay. Wow. Okay. Now I've already got like a number of questions brewing, but I know that you've got a presentation for us, so it may be that they're answered in that presentation. So would it be an appropriate time for me to pop that up?
Yeah, let's go.
Yet again, we've had a few technical hitches, so Cath is just going to be doing next slide, please, a little bit today. So let me pop it up on the screen. There we go. Hopefully everyone can see that clearly. Just let us know that you can see that on the screen, those of you who are watching. And thank you for watching as well. All right, so here we go. Is it next slide?
Next slide. Okay, so midwives work via a code, basically, and it was updated in 2018. So in terms of informed consent, we act in the best interests of people at all times, respect a person's right to accept or refuse treatment, maybe it should say decline treatment, and get their informed choice. It's a bit like the Hippocratic Oath: first, do no harm. Whatever you do should be consented. You have the right to refuse any treatment that's given. Whenever anything is recommended, it doesn't mean it has to be done. So this is really important as women who are birthing. It's something that's recommended in care. You can question that. Next slide. I just wanted to give you a sort of like brief overview of childbirth very quickly. I wanted to just bring up Mary Douglas. She's an anthropologist that spoke about the dangers of childbirth and how it's become a risk issue. Childbirth was seen as a completely normal thing in the past. It was an honoured transition. You'd become a mother. It was quite celebrated. And in the past, of course, you'd be looked after by female carers, traditional midwives, a known female friend. That was how pregnancy and birth was back in the past. But the concept of risk and danger are so culturally and politically situated now, especially in women's health. We know that now there's a sort of hierarchy, and women who have lots of choice where they want to give birth mainly give birth in a hospital. Even though we have wonderful things like the Barkantine, we still don't have as many women choosing this because they feel safer within a hospital setting. So it's really interesting to look at that. On Women's Hour today, actually, they were talking, we're constantly banged, poor midwives, because of Shrewsbury and Telford, where you have maternity services constantly failing women because there's a lack of midwives. And especially in London, particularly, we are very, very busy. We are a huge population. And in light of that, midwives constantly have to, I mean, during COVID, we had to change the care that we gave and everything else. It's quite difficult. What I've put here in the risk management regimes was to really talk about the 4-hourly vaginal examinations that you are recommended to have in your labour, is based on an industrial model of care, which was based on Fordism, which was actually how cars were made. So it's literally an assembly line. That's what is called. It's Fordism. So the focus is really labour must be completed within a certain time frame. So once you start vaginal examinations, you're meant to say, right, you're in labour now. So once you start on that sort of trajectory, you're meant to follow a certain timeline, which is very difficult to get out of. If you've declined vaginal examinations, or even if you've started on that pathway, they continue throughout your care on a labour ward. We'll change over to that. Okay, control of women's bodies. Attitudes to the body are shaped by culture and society. Obviously, we have perfect bodies shown to us all the time. Media portrayals of birth. You've seen one born every minute, which I cannot bear to watch. And so how we view birth is women are on beds. They're in the center of the room. They're elevated so that we, as caregivers, have access to a woman's body. We're a bit scared of women's bodies, basically. They leak. And this is back to a wonderful anthropologist that there's the leaky bodies philosophy of we're keeping them on a bed so that we can watch them and oversee what a woman's body does. So women are often on their backs, and you very rarely see, unless you're in a very sort of birthy world, women giving birth in pools or upright births, which is how we do that at the Barkantine. Like I said, most babies are born in hospital, and that's about visibility and about how we manage women. Next slide. Just to also give some context within the field of women's health, there's a history of misogyny, racism, classism, which illuminates a abhorrent context of assault disguised as care. You've got to think about Black women in the US with obstetric experimentation. You've got to think about the USA with its high levels of maternal mortality, the terrible medical insurance that women have there. And we're very lucky to have the NHS in the UK and so many choices in birth. So women really have to be educated about how that works and get access to the different options that they have. So similar practices persist in the modern application of pelvic care, vaginal examinations, ranging from overt sexual assault to coercion disguised as guidance. And there's a liturgy of women complaining about their birth or have PTSD. You must know that, Sheren, of just women who have come out of a birth and they are completely traumatized. And I'll go ahead. What are you gonna? No, just going to say just the disproportionate poor outcomes of BAME women, and remembering that Black women are almost 5 times likely to die from pregnancy and childbirth. So you're going into that, if you are from a BAME, you're walking into that knowing that fact, which is really scary.
Is that the same here, Cath, as it is in the States?
Yes. I mean, we are, yeah, it's 1 in 5. It's terrible. I mean, it is different from different ethnicities. Asian women is different. It's 1 in 4, but definitely Black women.
Gosh. We may discuss a little bit more about that later, depending on what kind of questions come in. It's a huge area of concern, isn't it?
Huge, huge. Yeah. So the next slide is just a lovely picture of one of our Bangladeshi women who the Barkantine's been open for 13 years. She's holding her fourth baby that was born with us. And that's the lovely Claudia, who's pregnant herself, just holding the baby. We can go to the next slide. So consent. Consent is a clear dialogue between individuals to engage in a specific activity. I'm going to do this to you. So you have to have clarity on exactly what that caregiver is going to do to you. If a patient does not believe they have consented to an examination, they can rightfully identify this with assault. So I just wanted that to be clear. We can go to the next slide. So improving practice, we look as midwives, we should be evidence-based. We should be looking and as such, look at a trauma-informed care and shared decision-making. We also have to deal with women who are lesbian, bisexual, queer, transgender, non-binary, anyone with a history of sexual assault. I haven't had many women with vulvodynia or vulval pain that have actually disclosed that to me. I deal more with women with FGM or female genital mutilation or with sexual assault. So that once they have disclosed that, we can make a care plan and work around that. But I've only ever had one woman with vulvodynia that did tell me, and it's thanks to Kay Thomas, actually, a good friend of mine, that actually informed me about that. We are not taught it in our midwifery education. I literally came to it through Kay Thomas, who's really enlightened me about the whole thing.
And I know that, Kay has mentioned that, often midwives haven't heard of vulvodynia. And perhaps there's this misconception that it just hurts a little bit, not a real idea of what it can be like. And, if going in, labor is painful, they might not understand the anxiety that woman has because there's, because of their vulvodynia experience as well. And I wonder, it's not in the curriculum, is it, when it comes to midwifery?
We do loads on FGM, loads on cultural practice, loads on sexual trauma, but not vulvodynia.
And why is that? Because, look, it is important to absolutely cover FGM, sexual trauma, all of that is so important. But with vulvodynia and vulval pain, when it's so common, and we're talking at least 1 in 7 women in their lifetime, but it might be more like 1 in 4. Now, even if it were 1 in 7, that's huge. And I imagine, Cath, as you say, one woman has disclosed to you in the time that you've been a midwife that they have had vulvodynia. But actually, if 1 in 7 women experience in their lifetime, it's very likely that there's been more than that one person who was experiencing vulvodynia. And are there questions that midwives can ask to maybe make it okay for that person to open up about what might be going on? Because ultimately, if someone is opening up about sexual trauma and FGM, why is it they're not opening up about vulvodynia? Is there something that needs to happen from the midwife side?
I think you really hit the nail on the head. It's really made me think about this doing this talk, because I suppose I deal with mainly Bengali women. So even talking about sex is quite difficult. I kind of thought, should I add it as a tick box with the initial booking appointment when I see women for the first time and say, we often talk around sexual stuff, but they're not very open. I think there's an embarrassment around it. And definitely as a midwife, when I have examined women vaginally, I've definitely known that there's issues around that. So you think, before I spoke to Kay, I suppose I thought this woman must have some sexual trauma, or just that oversensitization, not wanting me to do it, not wanting me to touch her. So it's the language around it. Possibly the woman that I did see had a very good relationship with her GP, and it was a female GP, and she had a good plan in place. But I think it's a conversation we need to have as women.
Yeah, absolutely agreed. And you talked about having a plan in place. Is that something you're going to go into in your talk?
Yes, I am.
Yes.
Really,
okay.
Yes. Absolutely. Can
Okay,
you go to
so
the next one? It's a really wordy slide. I apologize. It's just really, if we go to the second point, the reasonable patient standard, shared decision making and trauma informed frameworks are emerging. They're starting to emerge where you can bend rules, you can put in plans in place with women that have vulvodynia, sexual trauma, FGM. Especially FGM is that's existed for a long time, and there's laws against that. We have really strict laws as midwives. Also the language around it, Sheren, like you were saying, where I don't work on a labour ward anymore, but it's very difficult as a midwife, especially when I began to do vaginal examinations. I would say things that could be really triggering, like just relax, open your legs a little bit wider, all those things. It's difficult seeing yourself do that. Only when you can observe someone doing that can you see that that language could be triggering. And when things happen in birth and they can go from really, really wonderful to suddenly hugely traumatizing, because you suddenly have to, everything's gone really well, and then suddenly you have to perform this examination because you don't think that the baby's going to come, or there's a problem with the baby. So we have to do this. The language says, I'm doing this for you. Your baby could die. It puts women in a really difficult situation. People are really scaring you. So our language is hugely important. And at that point, in the fourth point, is someone declining care. It can get really triggering, some of that language saying your baby could die. What are you going to do? So it's hugely weighted with trauma and language and how we explain these things to women.
And Cath, of course, when it comes to communication, we're not just talking about the words that we use. It's that tone of voice, isn't it? The pacing of our voice. It's our facial expressions, our body language, how close we might be standing if we're leaning in. Just being mindful of those things.
It's also that women may not speak English. They may not understand what's going on. It might be a doctor doing the whole, I am going to save your baby, this is what we do. And you just women can become quite like a vessel and lose that identity to choose what happens to them. It's really, really important that those plans are in place before that happens. Or you have a caregiver or someone that's going to say, stop, or can you just know that this is what's going on with her. Also, just the mention of chaperones. You shouldn't really have any vaginal examinations without another person present. It should not ever be just one person.
Okay, great.
Also, wearing a mask, that's been really hard, where women are wearing masks. Thankfully, we didn't have women wearing masks in labour, but wearing a mask and doing a vaginal examination felt really weird. So I would always remove the mask. It was just really triggering, obviously, like a hand over your mouth. It was someone that I was looking after that said that and said, can I remove my mask? She was so scared of COVID. And I was like, of course you can. You're the one I'm examining. You don't have to wear this mask. But of course, COVID's been quite difficult like that. You can't see a person's face and it feels like you're being covered. So we've done a lot on sexual assault in terms of training with midwives and to recognize that, especially with FGM. And again, I've just mentioned that spread your legs wide, just relax. This was more sort of like backing up about how we can modify that or help a woman. Often we've got women who are doing hypnobirthing, which is really great, where they can just plug in their earplugs and just sort of go into it and say, can you just wait till I've relaxed? I'm just listening to music. Or they can talk to a friend that speaks their language, or breathing exercises. And of course, mask wearing during COVID. Take your mask off. It's just the next slide. Oh,
is that right? So, is that the next slide? Yes.
Yes. So when you're in labor, you are meant to be a certain amount of centimeters, and then they say that you are in established labor. And from that happening, then you are recommended to have 4 hourly vaginal examinations. Who is this for? Why are we doing them? As a physiological midwife, working in a birth center without doctors or without a timeline or Fordism, or working in that industrial way. I'm not overwatched by doctors. I don't have to move women along in and out because you've got beds that you're watching. And I do understand that that's really difficult on a 30-bedded labour ward, which is really busy in the centre of London. I often don't ever do one vaginal examination. My job is to watch and wait and look for outward signs that the woman is progressing. You can hear that, you can see that, you can trust that. So as a midwife dealing with physiology and trusting it and knowing it and being with women, if I was looking after you, Sheren, I would know the touch of your skin. I would know how you were dealing it. It's a very intimate thing, birth. And by watchful waiting and recognizing those signs, vaginal examinations are null and void. You do not need them. There's
a comment that's come in from someone who's watching. I was booked in for a C-section with my daughter because of vulval lichen sclerosis, which I don't know whether you're familiar with, is a vulval skin condition. And so she'd been booked in for a C-section because of the lichen sclerosis and the damage it caused. I went into labour early and the midwife decided to do a vaginal examination during a contraction. I nearly hit the roof. The pain was so bad. This is all whilst they struggled to put a cannula in as well.
It's not an unfamiliar story, sadly, and this is happening all the time. It's really sad. That's an awful story.
Sorry, yeah, so sorry to hear that, Emma. Thank you for sharing it, and I hope things will change.
Yes, yeah. So as I said, I don't know much about vulvodynia. What I have known is the wonderful things that Kay's told me, and to be more aware of that. It was interesting. I looked at 2 studies. There weren't many studies related to midwives, right. Actually. I found 2 that were useful out of all the ones I looked at. And just really interesting with vulvodynia, complain of burning or tearing pain, which can be constant, intermittent, spontaneous, unprovoked, provoked. So it's really interesting to know that it doesn't follow a linear, it's not linear. Vaginal examinations can be really, really uncomfortable in anyone who doesn't have vulvodynia anyway. So we've got to be really, really careful. And looking around it, in this study, it was really lovely where she had said, would you like to insert the speculum? And I'd never even thought of that, to say that to a woman myself. So it was really learning for me to think, wow, I could do that. Of course, she would know where she saw. I could hold a mirror up. I could help her do that, and that would also help with women that are particularly frightened with sexual trauma as well. So I found that really useful.
Have you brought that into your practice, Cath, having learned that?
I'm going to, definitely, and teach students that. I've never done it, so I'm definitely going to try that with women, definitely. So the next slide is just the 2 studies, Sheren, there. We can go on to the next one. So in those 2 studies, they were talking about women trying to get pregnant. That really made me think, gosh, that's really difficult. And they were talking about the timing of when they were ovulating to have penetration, which was really interesting as well. And a lot about resilience in vulvodynia and vulval pain. That horrible word, resilience. I mean, midwives always talk to be resilient. It's a difficult word to work with because it feels like you're coping, but you're not coping. Do you know what I mean? I find resilience really horrible. Also, this mistrustful attitude towards healthcare providers, that was really found a lot in the studies that I looked at, which is really sad. Even when healthcare was positive, most participants developed mistrustful attitudes towards future dealings with healthcare systems and providers. So it's the same old story. Even if it began quite well, they've obviously had, bad care or insensitive care in their pregnancies or births. So,
and sadly, with vulval pain, with vulvodynia, even in the lead up to trying to get a diagnosis, the care pathway may not be as comfortable as we might like it or as straightforward. It takes such a long period of time for it to get recognized. Perhaps the right questions aren't being asked. Maybe the woman isn't being listened to properly.
100% agree. Yeah.
And, we only have to think of, smears, with the speculum. And again, this idea, we've got a guide on the Vulval Pain Society website as to how to make that a little bit more comfortable. Doesn't mean it's going to be comfortable. And as you said, vaginal examinations aren't, they're not comfortable anyway, with or without vulvodynia. Do you think there's a need perhaps for pain relief?
I think gentle. I mean, obviously talking about that before, a woman knowing herself, just like I said about the speculum, I think there are ways of doing that. Pain relief does take you down a certain road. What kind of pain relief would be good? I mean, as an epidural would desensitize that area, but you're still, I think to try other modes maybe before you went straight down that, because if you have an epidural straight away, you're down along the road of continuing with an epidural, which might prevent you from being so mobile. It's a difficult one. It's really difficult. Okay. I don't know what other pharmaceuticals which wouldn't be opioid related, which again may not desensitize or help you with that at all either. The conclusions of the study were interesting. Pain-related experiences prior to pregnancy strongly informed decision-making during pregnancy. And women seem to reach a personally acceptable level of pain before planning and achieving their pregnancy, which is so sad. It's really sad. Again, they talked about resilience, and then the gap in medical care should be addressed with changes in screening policy and increased medical education. Midwives need to be taught this. Doctors need to be taught this. It should be part of normal care. It should be part of our normal birth pathways that women will have vulval pain. It should be there, and it's not, which is quite sad. I was thinking about having that at the initial booking, like I was saying, as a tick box. Have you ever had vulval pain? And when we ask them if they've ever had any mental health issues, which is a very personal question. But we're midwives. We should be able to say, have you ever suffered vulval pain? Do you find inserting a tampon? Is there an area that you find? We might be the first people that they speak to about this, which is really important.
There's a question here about lidocaine. Is that a possibility to apply lidocaine after birth?
I mean, we would do that as a cream, as a gel.
Yeah, so lidocaine comes as an ointment. It can be used for vulvodynia, 5% lidocaine. And some people find it useful and okay to kind of just numb the area.
I mean, absolutely. If it doesn't affect the tissue and you can do that, I would be totally, absolutely. I mean, lidocaine, we don't have it like that. We usually use it to suture women, so it's done as an injection. But absolutely something to think about. Yeah.
Okay.
Okay, the next slide. So this is the beautiful Barkantine. So our rooms, you can see, are like a home from home. So most women give birth actually kneeling on the mat on the floor, leaning forward, or in the birthing pool, or in the bathroom, or tucked in the corner. They can give birth wherever they want to. In fact, in 11 years, I've only caught 2 babies on the bed. So women naturally gravitate towards going on the floor or in the pool. And we have an outside space as well. So it's a really lovely design. It makes you immediately feel comfortable. And of course, remember, the focus isn't straight on the bed like you would on a labor ward. That's mainly for sleeping once you've had your baby. So again, the focus is completely changed.
This looks so comfortable.
It's great, isn't it?
It's lovely.
So next slide. So my recommendations, after really thinking about this, and Kay has really got me thinking, which is really good. First off, continuity of care. midwifery care, good, strong midwifery care, connecting early in your pregnancy journey to a midwife that you can develop a trusting relationship with, so you can have open, honest conversations. That continuity is proven in numerous studies to enhance and improve outcomes for pregnant women. And it's now a key objective in all maternity trusts. So if you meet a midwife, you can say, can you be my midwife? Can I just have you seeing me? Often you buddy system, you have another midwife. That's what we try and do at Barkantine. Doesn't mean we're there particularly for your birth, because we can't be on call all the time, but it means that we can have you at the beginning of the journey all the way through to when you give birth. Hopefully we're there when you give birth. And then we follow that woman up postnatally. So you only see that 1 or 2 midwives in your antenatal and your postnatal journey. Makes a huge difference. This also means you don't have to keep explaining your diagnosis of vulvodynia all the time to your caregivers, or to so many health professionals. And also early care pathways can be established, plans can be made and documented in your notes. And also that person, that midwife, could be the connection with an obstetrician or anyone after that, physio or whatever. You can be that midwife that says, look, I'm looking after Sheren, she has vulvodynia, this is what she wants. So it cuts you trying to get all those answers. That midwife can really, really help you. Birth physiology. Think about birth physiology. If you have vulvodynia, vulval pain, anything like that, a woman's body works better if it's undisturbed. We know this. We've known this for millennia. So a birthing space that is conducive to relaxation, dimmed lights, and known trusted caregivers, midwives good birth support from someone that you know is not going to panic, that knows exactly what you want in your birth. And this will reduce intervention and obviously reduce conversations. We don't really want talking in a labour room. You want it quiet. Your focus of care is that woman. And obviously the hormone oxytocin has a vital role in labour. Oxytocin is the sex hormone and it's the birth hormone. And we as midwives are queens of it, making lots of oxytocin. So just by simply dimming lights, putting beautiful music on that will make you feel calm, or no music, putting on capital radio, I don't care what will make you feel happy. And when oxytocin allows the cervix to dilate. And oxytocin goes hand in hand with lots of other hormones like relaxin, which all speeds up labour and makes it go at a pace that's good for your body.
And again, it's involved in trust, that bonding experience, and it's a natural pain modifier.
Absolutely. So birth planning, freedom to move around, use gravity and positions to help the baby through the pelvis. You do not want to be stuck on a bed. This is what I was saying about thinking about epidurals. You tend to stay on the bed. If you're in a labour room on a labour ward, you tend to be on the bed. That's how the design of the bed is, of the room is. So it's very difficult to get off the bed. You can maybe get off the bed to go to the toilet, but there's no mats on the floor. You have to, and also midwives within a hospital deal with really high risk women. And they're used to women that do have to have cesarean sections, or can't choose to have home births, or don't want to go to a low risk setting, are unwell, do have issues around birth. So they tend to look at women like they're going to have a risk. So it's good to think about freedom to move around. Think about where to give birth. Ask your trust. If you're low risk, choose a birth centre. Absolutely. There are midwives that have the same ethos and want women to use physiology to have their babies. Choose a home birth. Midwives you've got home birth teams hopefully in your areas. They're not working all the time, but if you have that opportunity, I would definitely start your labour, and the chance of you having a normal birth is quite higher if you're low risk and you've got good carers looking after you. If higher risk, consider a doula to advocate for you and help maintain physiology in the birth room. That is vital if you're having to birth within a labour suite. The other ones are consider hypnobirthing, which is really good for relaxation and focus. Women do really well at the Barkantine, if they've done any number of hypnobirthing. You don't have to do it throughout your whole pregnancy. Even a few weeks of hypnobirthing is really good. Use a birthing pool for labor. You don't have to birth there, but it does stop access to your vagina. Basically, you're in a pool, so it does prevent touch. It prevents people fiddling around. You're in the pool and you're deep relaxation, and that tends to speed labor up, and you're in an upright position, and positions that are really comfortable for you. And write a birth plan, which is really hugely important. A really well thought out birth plan how you want your labor to be. Things change, but as long as midwives have that, they've got a guide to looking after you. And you can, in that birth plan, say that I'm declining vaginal examinations unless they're really necessary.
Right. So it's that matter of consent again. If you've got it in the birth plan, then it's there in writing. Yeah.
Absolutely.
Yeah. Sarah says, where I am, you don't get your community midwife who sees you in appointments in labour. It's strangers when you go in for labour. Is that the same elsewhere?
I think there's such a shortage of midwives. We are in crisis. We're in total crisis at the moment. We're 2,000 midwives down at the moment. A lot of midwives are very tired and burnt out. That's not an excuse. We should be. I've got student midwives that are coming through now that are paying to be student midwives that have had a really rubbish time over COVID. Ideally, of course, it would be that midwife, but at the moment it's just maternity services are in complete crisis, if I'm honest with you. But choosing out of birth or alternatives, which they are considered now, like freestanding birth centres or home births, will guarantee you that you might know that midwife. So that's the closest I can advise, basically.
Yeah, we do still have that postcode lottery, don't we?
Yeah, we do, sadly.
Yeah. So that's your presentation wrapped up, I think.
That's it. Yeah.
And it's over to any questions that people have for Cath to come in. I think we've got a couple here already. I'm overdue, and a midwife suggested I have intercourse to bring labour on. This is not something I can do with vulval pain.
Again, it's the oxytocin. It's sperm contains prostaglandins. It's also it's just a thing that we say that is for normal women it would be a good thing to do. But yeah, obviously what we're trying to avoid is you to be induced. So they're saying what a midwife can say, saying try and do anything that is going to try and get your oxytocin up, and try and before you go into hospital, where they're going to offer you vaginal sweeps or they're going to offer you prostaglandins to try and get you into labor. It's difficult, really difficult.
I'm wondering, we've touched upon vulvodynia, and you were thinking perhaps bring this into the kind of questionnaire, so that we talk about it beforehand. And how can that be? How can we do that? You can do it at the Barkantine, perhaps. I know you train midwives, but how can we just make sure more and more midwives perhaps might start utilizing something like that? Because we do need to talk about this, and we do need to plan better. And we've talked about consent already. What are your thoughts on this before we dive into more questions?
I think you should be involved in conferences. I think it should all be part of that, someone from your society, and it should be involved in, as much as we talk about sexual trauma, we should talk about vulval pain. Like I said, I was unaware of it for years until Kay informed me. So as much as I was looking after women and examining women, I didn't know to even ask that question. But I think it should be part of the curriculum. Part of a taught area of midwifery. And yeah, obviously that we are women. I mean, having daughters as well has also, you know, I've asked, how did it feel to put a tampon in? It should be a conversation you have with women, shouldn't it? It should be, we should be open, and women should be, especially young girls, should be able to talk about that.
Yeah, absolutely. There's a question here about having an episiotomy or not. Will being cut take longer to heal?
It will take longer to, I mean, it takes 6 weeks to heal from giving birth anyway. In 24 years, I've done 4 episiotomies. So by using birth physiology and upright positions, you are reducing the chance of having an episiotomy. If you're lying on a bed, basically, and you're in a labour ward where episiotomies are still sadly quite routinely given, you want to reduce that risk, and that goes back to where you choose to give birth, who your caregivers are, and women who trust physiology. You be upright. You know, most women in all cultures, if you look at old paintings, if you look at art, birth art, women are upright. They're not lying on their backs.
Right.
And that will immediately change and reduce the risk of you having any perineal trauma.
Cath, where on earth did this thing come in that women lay down on a bed? Who is that? Who is that for?
That was Louis the 18th or whatever it was that wanted to see his mistress give birth. Yeah. So he lay her on her back, and he had a little curtain so he could see her giving birth. And then it became all the rage. Before that, we had birthing stools. So if you look at prior to that, birthing stools, women were upright, and it was, of course, it was the dawn of doctors entering the birthing world as well. So male attendants devising, instead of women midwives' hands, they created forceps, and to make space, they would make cuts. So yeah, we've lost a lot of birth physiology and trusting a woman's body.
Wow, there's
It's an interesting history.
Yeah, gosh, it's a shocking history. Yet again, guess what happens? It's not there to help the woman.
No, absolutely.
There's Catherine says there are NHS centres now introducing perinatal pelvic health services. There are 14 at the moment as early implementers, and there'll be a national rollout in 2023-2024. These services will focus on prevention and identification of pelvic health concerns, so will include asking all women in pregnancy about incontinence, prolapse, vulval pain symptoms, and sexual dysfunction. Well, that's great to hear. And Catherine Ross, thank you for that information. And Catherine's popped up a link as well to that news. So that's welcome, isn't it, Cath?
Excellent. Anything like that. Yeah.
There's another comment here. I suffered with symphysis pubis dysfunction. I have no idea what that is, Cath. Please explain.
So symphysis pubis is the bone above it's the pubic bone, basically. So some women have that kind of splits in the middle, and it can cause lack of mobility and a lot of pain. So women become quite immobile, and some women have ended up literally in wheelchairs from the baby's head being in the pelvis. So yeah, is that with vulvodynia or whatever, or is that something?
I don't know. So let's have a look. So I suffered with symphysis pubis dysfunction whilst carrying my second and third children. After discussion with a consultant, I was approved to have a water birth if I could prove that I could get in and out of the pool.
Yeah,
I did have a water birth with my third child. I would highly recommend it for added pain relief.
Great. Yeah. I mean, this is the thing with symphysis pubis dysfunction. You want to be able to be mobile how you want to move. If you're put actually in stirrups on a bed, it's far more uncomfortable. And that goes back again to choosing where you're going to give birth again.
Yeah. And choice is important, isn't it? Because it doesn't have to be because you've experienced pain, vulvodynia, or any of these kind of conditions, symphysis pubis. It is about choice again. Ultimately, This is this is your body, our bodies, and that choice needs to be there. And you were talking about shared decision making. Could you talk a little bit more about what that looks like, that ideal shared decision making process?
Yeah, so if I had someone with vulvodynia, I would definitely try and caseload her. And then I would contact a consultant obstetrician, definitely. We have a birth options clinic, which is great at the Royal London. So women who have had previous poor experiences, or women with vulvodynia or sexual trauma, FGM is a different matter. But so you can talk with a consultant and make a clear plan in place. Okay, I have vulvodynia. I would like to try for a normal birth. I'm going to try at the Barkantine. But if I don't manage to get very far in labor, or it doesn't work out, can I be admitted for a cesarean section? Do you see what I mean? So that you're sharing that onus on the woman with a consultant obstetrician and a known midwife to say, right, what is going to work best for you? And it's absolutely available. It's absolutely crucial for women to make that choice and to talk to someone that's going to be supportive. And when it works, it's amazing, because women carry on their pregnancies knowing that that plan is in place. It's the unknown that is so scary.
Right. It's a peace of mind, isn't it, if you have that birth plan? So would you recommend then everyone has that birth plan in place? If you're pregnant, make sure you have this in place.
Absolutely. Everyone should have a birth plan. I think it's empowering for yourself. This, like you're saying, this is your body. This is your choice. And that first baby, often they'll say, oh, why are you having your first baby at home, and the safety and the risk factors. This is your most important baby. This is the rest of your obstetric history. This is the rest of your gynae history. Try and do it the most natural, physiological way that you can, because most low risk, healthy women can have babies completely normally.
Okay. There's a comment here. I know women physios who are keen to recommend C-section if forceps or assisted birth looks likely, since most of the rehab they do is on women who have had forceps.
Again, it's a completely women's choice. I know that I have seen really poor effects from forceps, but then I've seen really incredible forceps operators in terms of really gentle forceps, if you can even imagine that. So I think it's, again, really difficult. I don't think I would choose to go to a cesarean section over having a forceps, but it's again, it's an unknown. I would want to have a birth vaginally as much as possible, but again, you don't know who's going to be on that day. You don't know who the doctor is going to be. So it is, again, an unknown. It's really difficult putting that plan in place. The risk of having a cesarean means that possibly you would have another cesarean for your next child, then another cesarean. So it's difficult.
Yeah, there's some choices to be made, aren't there? Another comment, I was told no stirrups. And I think this is, this is the lady who suffered with symphysis pubis dysfunction. She was told no stirrups, no delivery on back, no holding legs back. I would have to be on all fours.
Yeah. That's the main position women adopt. If you let them just do what they want to do, that's what women will do.
Yeah. It's that finding that natural position, isn't it? And I guess that natural position is going to be different, isn't it? I mean, it's not going to look the same in any two women. It's going to look slightly different, right? Cath, I wonder, do you have any, as we've, the people watching, of course, some of whom experience vulval pain, do you have any questions for our audience or for us to answer, or things that, you'd like to know?
I suppose how to open that conversation. Would it be good as an initial when you first meet that woman, or would it be good if you could bring that up much later in a pregnancy, or how do you ask it? It would be really good to know that.
And knowing, of course, there are people watching live, and this is something that stays up on our Facebook page and on our YouTube channels. And, you know, in the coming days and the coming weeks, as you know, suggestions might come in, we'll share that with you, so you can share that with your colleagues. I think that's a really important question. I love that you've thrown it back to the woman, you know, as the human being there. How do we as professionals, or how do midwives open up, you know, and ask about that and having that conversation? I mean,
it's a huge, that first initial booking has so many questions. Have you ever had a mental health issue? What have you ever had a medical issue? So it's you're filling in a book of that woman. There's nowhere there about sexual function or vulval pain or anything. So it'd be really lovely to know how to open that conversation. Yeah.
And whether it would be a good idea to add it onto that list. Yeah, it sounds like it would be a good idea.
Yeah.
Cath, I'm curious. You mentioned I can't bear to watch one born every minute. Why is that?
Because I suppose it's observation. And women are on the beds, and there's bright lights and different caregivers, and I know that birth doesn't work like that in any mammal. And it's just uncomfortable viewing. I just find it really, I don't know, I just can't watch it. Sadly, we were once asked if we could do filming at the Barkantine, and we had to decline, because as soon as even a camera's in there, you're introducing eyes.
Yeah.
And women just change. You know, the thing is, you've got to keep it sacred and silent and protected. That space has got to be for women's bodies to really function, is make that an enclosed, sacred space. So yeah, it does make me feel uncomfortable.
Yeah. And you know, one of the things I cannot stand about TV shows and dramas is how, you know, birth is depicted.
Yeah.
You know, it's not, no one is saying it's going to be comfortable, but the way it's depicted and the positioning is something that makes me pull my hair out.
Oh my God. Tell me about it. Tell me about it. I mean, they just think so much blood is going to happen and waters are going to burst all over the place. Actually, birth can be really tidy, and women look like goddesses when they're really, really in a space that they feel comfortable with. And if they don't look like goddesses, there's something wrong. And that was something that Ina May Gaskin, an amazing midwife, wrote. And you really do hold that true. If women don't look incredibly beautiful in labor, there's something wrong. It's a beautiful thing to do. It can be such an incredible transition. You know, your body is incredible. And if it's respected and you have caregivers that really honor you and look after you like that, it's an amazing thing. I wouldn't be doing it 24 years later.
Yeah, absolutely. I think that's a beautiful way to wrap up, isn't it? That it's meant to be a thing of beauty. All right, top 3 points then, Cath, for people to take away from this.
Choose where you're going to give birth. Really, really find out your options. Really do, especially if it's your first baby. It's your most important baby. So this baby could be the rest of you having 3, 4 babies. It's you being an older woman, you know, that doesn't want trauma. So avoid that by choosing where you give birth. Second, choose caregivers that you trust and know. If you can't find a midwife that you don't trust and know, then choose a doula. Doulas are amazing. They can really help when everything goes wrong. They can help in every situation. They'll help you postnatally, and it's a face that you know and you've had those discussions with, that you can just let go and birth and have that person protecting that space. And third, just talk. Be open. Once you've found that special person, that special midwife, just let's have open, honest conversations, you know, and it would inform us. We have so much to try and write down and know about a woman, but it would be great if you can inform us and we can learn from you.
Yeah, and back to that shared decision making again, have the birth plan in place. Yeah, brilliant. Cath, Reeve-Jones, wow, thank you so much for joining us. That was brilliant.
Thank you. It's been lovely. Hello, Kay.
Kate is in the background. I know she'll be very jolly that you're on. And actually, I think that must be Kay saying, I would think you would need to ask it right at the very beginning, Cath. Opening up that conversation. There you go. She says hi. So those of you watching, whether you are watching live or on the replay, I've got some really exciting news. All being well, our new website goes live tomorrow. There may be moments where it's not quite showing, but just bear with us. By Thursday, shiny new website. We hope you like the new look. It's going to be easier to navigate across all sorts of devices, and we'll be adding in woohoo, says Sarah. Yeah, we're woohooing as well. We'll be adding more resources as we go along. A huge thank you to Catherine, our Vulval Pain Society teammate, who has been striving for so long to transfer all the stuff, the huge amount of stuff we have on our existing site over to the new one, and more. So thank you so much, Catherine. You know, we absolutely do appreciate you. And Richard, who's helping with the migration tomorrow. My goodness, I can't believe it. It's been so long. We're so grateful for everyone who chooses to volunteer to help us, and ultimately, you know, you're helping us to help you better. So the new site, same address, vulvalpainsociety.org.uk. Certainly by Thursday you'll see it up. So Wednesday the 7th of July or Thursday the 8th of July, you'll see it up. So here at the VPS, we have a lot of time for expert patients, and especially those who choose to raise awareness. So I'm pleased to announce that our next live stream guest is the brilliant Marion Jones from Pudendal Neuralgia Awareness UK. Topic, of course, is pudendal neuralgia. Alongside Marion will be my fellow trustee, Dr. Winston de Mello, who also has had a lived experience of pudendal neuralgia. So we're really looking forward to this discussion on causes, symptoms, treatment, and that lived experience. And we hope that you'll join us for that. Remember, as I think Kay's already put up in the comments, we've got past Ask the Expert webinar recordings on our YouTube channel too, and our live streams are both there and on the Facebook page. So you can watch, rewatch, comment, share anytime you wish. And we'll be experimenting with having some of them up on our new website from tomorrow too. Do follow us on Facebook, YouTube, Twitter, and that way you can be kept up to date with our future events, of upcoming events, and anything else that we may be doing. We will have new ways for you to contact us soon. In the meantime, you can email us info@vulvalpainsociety.org. That's all from the Vulval Pain Society now. Thank you again, Cath Reeve-Jones.
Thank you.
Cath, has someone just joined you there?
She's gone now. She's gone now.
And thank you everyone for joining us live and on the replay. See you next time for our Pudendal Neuralgia special. Bye for now.